Hello, in this module we want to look at interventional ultrasound and how ultrasound can help to make punctures, aspirations and drainage safer for the patients. Before we look at punctures and interventions, let us look at this case which was referred to me from the short stay, which was referred to me from the admission unit, and it is an 8-year-old boy, HIV positive with chronic cough, weight loss and increasing shortness of breath. Because of the chest x-ray, which shows a large opacity on the left side, the clinician had already twice tried to puncture and drain the assumed pleural effusion. As nothing was produced, and the boy was quite annoyed with this, with these punctures, the case was referred to me to see if I can help with ultrasound to see where the effusion is exactly located. So when the boy came to the ultrasound, this is what we saw, and as you can see at the right side of the screen, there is the spleen, and then on top of it there is intermittently you see the diaphragm here, and then you see these structures, but the black rib shadows. Of course you remember from the module on fluids that pleural effusion usually is homogeneous, anechoic, or at least hypoechoic, possibly with septa and strands, but generally it's a very homogeneous and hypoechoic area. Here it's different. There is a very small anechoic area up here in the pleural angle, but just on top of that you see the white reflections, which are probably air in the aerated lung. So this is not an effusion. This is the sign of a pneumonia, of an infiltrative process. And so I said, well, okay, sorry, I cannot puncture this boy because there is no effusion that can be punctured, and this is the reason why you did not get any fluid out. When we dig then a little bit into the chest x-ray file of this boy, you could see that he was already seen twice in the year before, and there was an infiltrate which seemed like a lower lobe pneumonia in March 2007, and by June 2007 this had increased, and now by March 2008 this consolidation or pacification was filling the whole lung. Actually, what you could also see is that the trachea was deviated to the left, which of course is less indicative of an effusion, which pushes the trachea away from the lesion, but more towards a shrinking process which pulls the trachea to the same side. So this is a chronic carnification due pneumonia due to TB. And this is a newer video which shows the same. You can see there is the hypoechoic lung, but it is not homogeneous like fluid would be, but you see the echogenic bronchi, you see the air bronchogram in the lung, and of course there is very, very little effusion around that, so this is definitely not something to be punctured. Okay, let us now look at the different effusions and how we can find them and what needs to be considered when puncturing them. Let's start with the pleural effusion. Where are they found? They are obviously found in the thorax, and particularly in the positions 2 and 4 in these 6 positions of the FASH scan. So this is you look from the right flank as much dorsal as possible so that your hand is touching the bed, and then you look above the diaphragm, and then analog you do the same thing on the other side, on the left side flank, longitudinal scan, and as far dorsal as possible in the supine patient so that you're sure you're reaching the most dorsal area where the fluid would collect. You can have to remember that ultrasound is more sensitive and more than X-ray. So even if your X-ray shows no effusion, it might well be that ultrasound does. Usually an X-ray needs about 300 milliliters. If the patient is supine, maybe even 500 milliliters before you can detect it, whereas the ultrasound can detect tiny amounts of even of 30 milliliters or around that. This is an example of a large effusion. So here is the spleen. There is the echogenic diaphragm visible. Here you see the vessel. That's probably the aorta. And then you see this homogeneous area, dark anechoic, which is representing a large pleural effusion, which can be tapped. And here you can see the position of the transducer on the left side of the thorax. This is another example, more towards the right side. There is the liver here. There is again above the liver is the echogenic diaphragm, which separates the abdomen from the thorax, and then on top of it is this homogeneous anechoic area, which is fluid, and this echogenic structures which are inside are probably compressed lung, which is floating in the pleural effusion. What causes pleural effusion? And I think that's good to remember before you puncture, to see if the puncture and the aspiration for diagnostic purposes can help you. In our experience in hospitalized African patients in Malawi, this is approximately the distribution. So in HIV negative patients, the most common cause are heart disease, cardiomyopathy, and others that lead to most often bilateral effusions. But of course, then the second most common thing are bacterial pneumonias, parapneumonic effusions, emphysema, so that are more infectious and that are of course often more unilateral. The TB plays a role with 15%, and then of course malignancy, and then a few others like liver and kidney disease and with fluid overload can also lead to pleural effusions. In HIV positive patients, it's a little bit different. The TB plays a larger role, so there approximately 40% are due to TB. And malignancy, and particularly Kaposi sarcoma, is known to cause effusions in all serotypes. It can cause pleural effusions, pericardial effusions, and ascites. And then the others are less frequent, as you can see here. Of course, the cause, so it depends heavily on the setting, on the history, on risk factors and clinical symptoms, and these need to be investigated before. But diagnostic and also therapeutic pleurocentesis can help in the diagnosis and of course in the management. Just to mention a few rarer causes, because we don't want to drop them completely. They are certainly rare causes, but they are important. That's pulmonary embolism and lung infarction can be a cause of smaller pleural effusions. Hyperproteinemia and hypothyroidism may be mentioned. When you puncture, it is usually done in a blind technique. Here in this example, you see it with an ultrasound probe in place and with a guided intervention. There is a drainage catheter inserted. What is important is that you use maximal sterility. I mean, whatever you can afford. So there should be well antisepsis of the skin and a local anesthesia if a larger needle is used. And then the fluid is drained, and the fluid that you should be aware that you shouldn't drain more than 1 to 1.5 liter in a single session, as the procedure becomes more risky the more if you drain more fluid, and you can get complications. Let's look at the pericardial effusion. How do we find pericardial effusion? Then that is clearly the position 1 in the FASH scan from the epigastric angle looking upwards, and that's where you find the heart, and then you might see this anechoic, hypoechoic, homogeneous rim around the heart, which is the pericardial effusion. causes of pericardial fluid. Again, from experience in our setting, that is for HIV positive and negative patients, the most common cause of pericardial effusion is TB. And so this is certainly a finding that deserves empirical TB treatment. The one thing that I would definitely rule out, especially in HIV positive patients, is Kaposi sarcoma. So you want to check the palate, you want to check the skin if there is no sign of Kaposi sarcoma, because this is a very common cause as well for pericardial effusion. Heart diseases, cardiomyopathy again with fluid overload, liver disease, kidney diseases again with fluid overload, they can cause fluid in the pericardial sac as well, and so can hypoproteinemia. How is the pericardiocentesis done? And if you look in the textbook, then it's usually done from a subxiphoid approach. There is a local anesthesia applied, and monitoring is attached to the patient. Then a drain is inserted in Seldinger technique, and that is the common way that is described from the subxiphoid region. If you use ultrasound, you can as well try to find a transcostal leaf to find some fluid pockets, and then you can use just a normal IV cannula, like we use it for a pleural tap, and try to reach the pericardial effusion through a transcostal approach. That is certainly easier, and less technology is needed. So in our setting, this is the more common way that we use. You want to drain here. You do not do a pericardiocentesis only for diagnostic reasons. That's what we would rarely do. We would mostly start empirical TB treatment. We would only do it for if there is tamponade or impeding tamponade in a patient and he is hemodynamically unstable. If you find that, you can drain a little bit of the fluid, like 100 mils or maybe 200 mils. Usually that is enough to relieve the symptoms of the tamponade, so there is no need to drain the whole pericardium to dry. Let's look at ascites. Where can we find ascites? And it's usually found in the positions 3, 5, and 6. So from the right flank between liver and kidney. We look at the Morrison pouch from the left flank between the spleen and the kidney. We look at the splenorenal recess, or sometimes called Coller's pouch. Then of course suprapubic we look at the Douglas pouch. And it is important that you also pay attention to small anechoic triangles between the bowel loops that can be signs of small amounts of ascites. This is how it looks. So this again, it looks pretty the same. It is fluid. It is homogeneous anechoic, hypoechoic, anechoic area, and this is the liver, which is surrounded by the fluid. This is another example. In this case, the liver is very nodular and very irregular, so most probably in this case, this is due to liver cirrhosis, and that is probably already the cause of the ascites. Here, deeper in the lower abdomen, there are bowel loops which are hanging on the mesenteric root, and surrounding is this black anechoic ascites surrounding the bowels. What are again, let's look at the causes in our patient population. It depends, of course, again on the HIV status, but generally in both HIV positive and negative patients, liver disease, so particularly hepatitis B associated or alcohol associated cirrhosis, and schistosomiasis are the most common cause for ascites. In HIV positive patients, TB and other infections put quite a significant proportion, and it might be a good alternative diagnosis if the liver looks normal. Heart disease, of course, can through fluid overload lead to ascites, particularly when right heart failure is involved. And one thing that you need to consider, particularly in female patients, ovarian cancer. So it's always worthwhile to try to examine the ovaries to see if there is ovary cancer as a cause of ascites with peritoneal carcinosis. Good. If the case is like this in this patient and there is a huge ascites, ultrasound guidance is mostly, of course, not needed, but it becomes a good habit to just scan before you prick a needle in, because it is just good to see that there is no bowel or no other structure underneath, and that your needle can go safely into the fluid. What are the risks? Of course, if you have patients with cirrhosis, then they often have also coagulation disorders, so bleeding is a problem in this patient population. As I said, bowel or organ perforation, if you do not look before where is your needle going, and infections of this ascites with a bacteria. So therefore, antisepsis is required and certainly important. How much do you want to drain? That is a bit dependent, because mostly this is done to relieve the patient from symptoms of this abdominal tension. So you want to drain as much as possible, but at the same time you don't want to cause hypovolemia and impair with the circulatory function. So usually it is safe in our setting to drain about 5 to 6 liters. If you can substitute albumin afterwards, you might drain a bit more, but albumin is expensive and is rarely available for us. A few words on the technique and the principles of interventional ultrasound. That basically there are 3 techniques which are commonly used. The first one is the blind technique, or almost blind. What you do is you try to locate the effusion, let's say an ascites. You see if there is where the pocket is that you want to puncture. You mark the point on the skin, and then you move the transducer away, and you insert the needle in without seeing it when it enters the body. So that's why it's called blind. The second technique, which is probably the most commonly used, is the freehand technique. So that is, you find the structure, the target structure with the ultrasound probe, then you insert the needle just next to the transducer, and then you keep the needle and the transducer on the same plane, and you follow the path as the needle enters into the body, and you see you see it going towards the target. The third option, and that is shown here on the right side, it's not very commonly available, but it is the most elegant technique, or the most technical technique. That is, you use a transducer with a needle guide, and as you see, the needle guide is fixed usually on one side of the transducer, and then the path that the needle will take is previously defined, and you can see it on the screen. As you can see on the image down here, you know that the needle will come this way if you insert it through the needle guide. That is necessary if particularly when you puncture very small processes and you need to be very exact, but most commonly it is not available to us. So how does it work? Let's summarize that again. So first we assume there is this target, let it be a lymph node or whatever, a tumor that is here. So with the transducer, we first need to fan until we find the lesion and have it in the plane. So that is here you can see here. Now there is this circle which shows you that the target is in the plane of the transducer. Then you adjust the transducer in a way that that your needle path, either you use a needle guide or you just imagine the path that your needle will be coming when you're doing it in freehand technique, that you safely reach the target. And then when you have that, you insert the needle, and then you basically follow you follow it going in, and you see when it reaches, and when it is in the target, then you know to stop advancing the needle, and you have hit the target, and you can aspirate or biopsy, whatever is the task. What are risks and contraindications? Well, obviously, if you stick a needle into some patient's body, then there is a risk of bleeding. And of course, if you have impaired coagulation, then this risk increases. So what would be ideal to look at that the prothrombin value, the Quicks value is more than 50%, and then the platelet are above 50,000. And that would be an INR of 1.5, and the platelets are above 50,000. If there is any underlying disease like severe uremia, which interferes with clotting, or severe anemia, which makes bleeding even more risky, that could be possible contraindications that could be considered. Another important thing is that you don't want to puncture dangerous targets. So obviously you want to avoid all aneurysms and vessels. That's the reason why you use the ultrasound. Pheochromocytomas you don't want to puncture because they can cause problems. And echinococcal cysts, that is a relative contraindication, as therapeutic drainage is a possibility. And of course, again, a relative contraindication is a long and dangerous route to the target. So if there is a lot that you can injure on the way, then you better think twice to do that. Local infections, if you have to pass your needle through an abscess, that would be, of course, spreading the bacteria further. And if you have a massive biliary dilatation or congestive heart failure, then liver biopsies should also be considered with caution. But in general, it is relatively safe. So if you look at this, it's a Danish article that was done a long time ago, and they looked at 3,500 fine needle biopsies, and there were only 7 complications, which is a rate of 0.2% only, and only 1 death occurred. And so it is generally can be considered as relatively safe, but of course you need to consider the risks and the contraindications nevertheless, and you need to inform the patient, and you need to consent the patient that this intervention is done. If you do a diagnostic puncture, what do you want to send? Why do you do it? Well, one would be chemistry, so cell count and cell type, LDH, protein levels. You can use it for alarm tests. That could be chemistry, especially on fluids. Of course, for pathology, we can harvest cytology samples, and if we use larger needles, we can get histology samples. For microbiology, well, it can be used for microscopy, gram stain, culture, and the gene expert that can also be used. There are different types of needles depending on what you intend to do. The aspiration needles are usually finer needles, like this Shiva's needle here is a very long. In the end, it is very similar to a lumbar puncture spinal needle. It's just longer, and often, if you don't have the target far away, you can even use a normal injection needle that is on a 10 cc syringe to aspirate material. If you want to get material for histology, then there are mainly 2 types. There is the more Mengini needle type that is shown here, which sucks the sample into the needle and then and then cuts it at the end, and the true cut needle, which has a groove and cuts more towards the side. Finally, there is a pigtail catheter shown here that is more for therapeutic drainage, and we'll come to that later. How does the Mengini biopsy functions? Basically, you insert the needle under the skin and towards the target, then you aspirate the syringe so that the vacuum is created, and then you advance the needle into the liver, usually the liver or the tumor, and so the material the cylinder is sucked into the the needle itself, and there is a little device in the needle that prevents it from spilling into the syringe, and then the whole needle is, with the suction applied, is extracted, and the material is taken out and put in formalin. So that is an end cutting needle. The true cut needle biopsy is a little bit different. You can see it here. This is the groove at the beginning of at the tip of the needle, and this. So what happens is that the needle with the outer sheet is advanced close to the tumor or to the target. Then the inner part is entered into the tumor, so material of the target gets into the groove, and then the outer sheet is advanced so that it cuts the material, and then the whole thing is taken out, and you have the material in this groove, which can then be put in formalin. So these are the two types: end cutting needles and side cutting needles. So lymph node biopsies. Let's start again with a clinical case. This is a 34-year-old male HIV positive patient with a low CD4 count of 144, so it's advanced HIV disease. He was seen with general malaise, weight loss, and swelling under his arms. As you can see on the images, it was more pronounced on the right side than on the left side. Swellings were felt to be lymph nodes, and they were larger on the right side. What is the differential diagnosis? The differential diagnosis of lymph node swelling in HIV positive patients is, of course, a pretty clear one. There is one that is Kaposi sarcoma, definitely can be a reason for lymph node swelling, so we should watch out for lesions on the skin and the mouth. Lymphoma can be, they often cause larger nodules, but these are relatively large nodules. HIV lymphadenopathy or persistent persistent generalized lymphadenopathy, that is usually more symmetrical and as more generalized as the name says, and it's more it's more common in early stages of HIV. Local bacterial and fungal infections, of course. In this case, lymph nodes are often tender, inflamed, and they might be purulent. And often you can see that there is a local infection in the drainage in the area drained by the lymph node. And then, of course, a very common thing is the cold abscess. It's the TB lymphadenitis. So if we have a look with the ultrasound in this case of this man, what do we see? Well, we see multiple nodular glued together nodular structures, which are most likely lymph nodes, which we thought before, and so that's what we learned. What did we learn much? Not really, because before we had this differential of lymph node swellings, and afterwards it's the same. So if you want to get further, you need to aspirate a little bit, and in this case we aspirated some purulent material, which was sent for acid-fast stain, and it showed acid-fast bacilli, so it's most likely to be a tuberculosis as the reason for the lymphadenopathy. Lymph node TB is well known for ages, and it is also called scrofula, which is derived from the French word for a full-necked pig. And it is also known as king's evil, because in the old times in Europe, it was believed that if a king touches the lymph nodes, then they disappear and shrink away. It never was proven that this really works, but it was a belief. The main cause in Europe is Mycobacterium scrofulosum and other mycobacteria. In Africa, the most common cause is by far Mycobacterium tuberculosis. It affects the jugular lymph nodes, posterior triangle, supraclavicular nodes, and but also axillary and inguinal. And as we mentioned, the diagnosis can be done by fine needle aspiration. How does the fine needle aspiration works? And here you see with the linear probe, so this is very superficial. This is only 1-2 centimeters under the skin. You can see that a needle is under ultrasound guidance advanced into the hypoechoic node here, and it's then suction is applied, and it is then sampled in and out to obtain material. And I show you on the next one. This is the clip. This is the same patient. You can just not see the screen that well here. You can see the clinician has the syringe in his hand, then suction is applied, and then the needle is advanced and pulled back to sample a couple of times, 5-10 times, to fill the needle with material. And what you can do is you can then flush, take 1 cc of normal saline in a red top tube, and you just flush the needle using that normal saline, and then you submit that for Gene Expert. It works quite well, and if it's positive, of course, that proves that there is Mycobacteria tuberculosis. There's a different patient. He was seen after he started ART a couple of weeks ago, and he also complained about this swelling here. And if you look at the ultrasound, and there is a little bit of compression on that, you see that there is what is called the squish sign. There is something moving like fluid in this lymph node. So again, we said, let us see what it is, and let us aspirate. And here you can see the same setup and the same clinician advancing the needle, and as the needle is advanced into the node, you can see that liquid material can be aspirated through the needle, and that is, of course, that is good, because you have sample that you can use to send it to the lab. It is filling the syringe, suctioning more and more material. Now he leaves the needle in and takes the syringe off, because basically the needle is full, the syringe is full, and here is the pus that was sucked out, and that was again due to tuberculosis, and then this is an iris phenomenon in this patient who started ART recently. Not only can you puncture lymph nodes, but I just want to mention this, it's a bit more invasive, so don't try at home, but you can. This is the spleen, and if you're not sure what processes these are in the spleen, and at that time when this video was obtained, we weren't sure what these hypoechoic lesions are. You can aspirate the spleen as well. It is done, for example, for visceral leishmaniasis diagnosis, but in this case today we would know that this is very suggestive of TB, and we would just try empirical TB treatment. Okay, let's next look at drainage and abscesses. So we start again with a clinical case. This was the 56-year-old woman who was seen at the Lighthouse Clinic, HIV positive, on ART, long time, virologically suppressed, but she complained about increasing right shoulder pain for a few weeks and swelling. For her past medical history, she had high blood pressure on HCT, but otherwise it was unremarkable. This is how her shoulders looked. So this is the left shoulder, and you see the scapula through the skin, and then this was the normal shoulder, and the right shoulder compared to that, you can't see the scapula. It was all swollen, it was all enlarged. So what we decided is that we do an ultrasound of that region, and obviously there is we don't know exactly how this area looks, but the good thing is you can just compare the two sides. And this is the healthy side. You can see there is the skin and the hyperechoic skin, then there is this muscle, and then there is the echogenic line, which is the scapular bone, and then behind the image ends. On the other side, as a comparison, we have again the hyperechoic skin. Then we have this very hypoechoic area under the skin. Again, then here is this is the muscle, and then down here we have the bone. So, and you can see already that this hypoechoic area here, it is compressible. That looks very much like fluid. that could be aspirated, which we did, and it's just a centimeter away, so we just used a normal syringe and a normal needle, and we aspirated this creamy pink colored pus, and we gave that, we put that in a tube and sent the patient with this to the surgical outpatient department for proper drainage, because this is of course a tropical pyomyositis, or a large subcutaneous abscess that needs drainage. Here, just this is in a different patient, but just want to share this with you. So this is you can have you can see a lot of pus that can be there. So that is this disease of pyomyositis, which has nothing to do with HIV. It can also be in non-HIV patients. If we want to drain using a catheter, then we commonly use this pigtail catheter. That is a pigtail catheter. There is a trocar in it that stabilizes it, and when you insert it into an abscess, it is a straight thing. But then when you are inside, you can advance the tube, and then the tip forms this little, like a pigtail. It forms it rolls up and get curved, so that it prevents dislocation a little bit. And then you can use the lumen to flush normal saline in and to aspirate. This is particularly helpful when it comes to deeper structures like this abscess here in the liver. Of course, that cannot be drained in an outpatient setting in the outpatient department. So you insert the needle, and then here you can see that the hook forms as the trocar is retracted, and then the pigtail is left in situ to drain the abscess over a couple of days. Here's another example of a liver abscess that has this anechoic fluid in the center, and it was drained, it was aspirated, and after aspiration, this is how it looks. It was certainly much smaller, but there are now echogenic area, which is most probably air that entered, because when you enter the needle and you aspirate, then air can enter into the cavity that can cause this echogenic reflections, and this is the sign of gas. Of course, if you have not punctured the patient before, then this gas is usually a sign that this gas was formed inside, and then it is a sign of bacterial infection and gas forming, for example, anaerobe bacteria. On the technique again, some words. Well, the drainage we looked at, there are two different techniques. There's the Seldinger technique where you puncture with a thin needle, and then you insert a wire, and then over the wire you insert the drainage catheter. That is a bit more complicated. The trocar technique is a bit more easier, because you as I said, you have the trocar stabilizes your catheter, and you can insert it directly. The Seldinger technique has the advantage that it is a bit more exact. The pigtail catheter we looked at. There are also so-called basket catheters, which are a little bit more like a Foley catheter with something, and again a basket that opens and can close to prevent dislocation. The problem with all these drainage systems is that they need care, and often nursing care in our settings is a little bit limited. So what often is a better approach is just to aspirate as much material as you can, either in a single aspiration, or even if you need to repeat it once or twice on consecutive days, to aspirate and to get as much material out. And if you can put the patient on an effective antibiotic treatment, this is often suffice to clear the infection after a few days. So that is a simpler and in our setting often more manageable approach. But of course, the putting a catheter is more elegant, but there are problems with that kinking of the catheter, dislocation, and so it is often it needs a lot of follow-up, and it needs a bit of nursing care. Finally, we want to look at central venous catheters and how ultrasound can help us there to place IV lines, and particularly central lines. Of course, they are mainly used in critically ill patients, and the mostly in ICUs, with the goal to ensure that stable administration of medication and nutrition can be given, and to monitor central venous pressure. And of course, it's in a way similar, like the approach is very similar to what we saw before. It's mainly using the Seldinger techniques today. So a needle is inserted into the vessel, then a wire is thread through the needle, and then the needle is pulled out, and the central line enters the vessel via the guide wire, and finally the guide wire is removed. So that's the approach that is most commonly used. And why do we want to have the help of ultrasound? Because the neck is a pretty busy area, so blind procedures are possible and clearly were done for many years, but they can have serious complications like accidental arterial puncture of the carotid, hematomas develop then, and even stroke if you're unlucky, pneumothorax. So if you know where you stick your needle, it is certainly helpful, and ultrasound can help you on that. So here we can see where the neck of the patient. This is the position of the probe here. This is a longitudinal along the neck, and you can see there is down here there is the pulsation of the carotid artery, and on top there is this in blue, there is the pulsation of the internal jugular vein. Doesn't help that much longitudinal. Some people do insert them longitudinal. I prefer to use a transverse scan, so that you just put the probe perpendicular to the needle path. Then you identify where is the artery and where is the vein, and then you push the needle forward in the direction of the vein. If you're not sure whether it is an artery or a vein, just remember this trick of venous compression. I mean, obviously the pressure is much lower in the vein, so you can easily, with a little bit of pressure, you can compress it. Here you see the artery, here you see the vein with very little pressure, and if I press a little bit more, the vein collapses and only the artery is visible. So I know that this is the vein. Let's see that in a video clip again. Here is the artery, and you see the pressure is applied intermittently, and then this vein, the jugular vein here, collapses. So we know that this is the vein, so we can put our needle here and we can safely insert the wire and place the central catheter, and hopefully we have quickly this result. But finally then the central line is exactly in the area of the right atrium where it belongs.